Hello folks, welcome to our lecture on the nervous system. This is a pretty big, very comprehensive lecture that's going to cover a little bit of everything: anatomy, physiology. We talk about diseases of the nervous system, some interesting ones, some slightly scary ones you've probably heard of in the news, ones you probably haven't heard of in the news. And we will spend a little bit of time at the end of the lecture talking about behavioral diseases, psychiatric diseases, with the full disclaimer that I am not a trained psychologist, but will do my best with what I know. So these are our objectives for the lecture. As always, know these for the quiz and the final in that case. So the nervous system controls your body functions using electricity. This electricity is controlled with chemicals that we call neurotransmitters. This is the second of our two body systems that we see that control the body, the way that the organs and the brain communicate with each other. The first one that we talked about was the endocrine system, which did all of that using hormones. Which of the two do you think is faster, the nervous system with its electrical signals or the endocrine system with its hormones? Definitely the nervous system. The nervous system can target exactly which organ or gland or muscle it wants to activate. The endocrine system, we have to put that hormone in the blood, and it will eventually circulate through the body and finally reach the organ that it's supposed to get to. So this is the main way that we coordinate everything that's going on in the body. The nervous system picks up on stimuli within the body and outside of the body, and then allows the body to change in response to that. So when we say stimuli, this could refer to any number of things. This could be changes in temperature. It could be changes in blood pressure. It could be changes in levels of calcium or glucose in your blood. It can be changes in the light that you're exposed to, how much sunlight is coming into your eyes, whether or not it's day or evening. All sorts of things that count as stimuli that the body is picking up on. There's some terms here, these guys in red, that you should definitely know for the quiz. Sensory receptors send information to your spinal cord. They're picking up on information. Maybe it is a temperature receptor that's picking up on something that's very hot. It's going to send that information to the spinal cord. The spinal cord will then send that information to the brain. The spinal cord is like the I-25 of your body. All of the information that it gets is being sent up to the brain. The brain then will take in that information, organize it, interpret it, make decisions, and then it will send those decisions through neurons, motor neurons, back down the spinal cord. Nerves are our means of connecting to the spinal cord. These carry information all throughout the nervous system. We'll look a little more in detail at what nerves are and what they do. The nervous system can be organized a couple of different ways. We talk about two structural divisions in the nervous system that you'll hear me refer to a lot: the CNS, or the central nervous system, which talks about the brain and the spinal cord, and the PNS, or peripheral nervous system, which is all of your nerves. The CNS, the central nervous system, is everything that you find in the skull and the spinal column. We can also talk about divisions based on what the different parts of the nervous system do, and we call these functional divisions. We have a somatic and an autonomic nervous system. And throughout all of these lectures, you've heard me refer to stuff that is involuntary versus voluntary and involuntary muscles or glands. This is where we get to the breakdown of who controls what. So the somatic nervous system controls your skeletal muscle. The word soma is Greek, and it just means body. So somatic nervous system is controlling the muscles of the body, all your voluntary skeletal muscles. The autonomic nervous system, this is all of your involuntary stuff. So this is smooth muscle, cardiac muscle, glands, all of those, all the baseline keeping you alive that you don't need to think about. Your autonomic nervous system can be further broken down into two divisions, the sympathetic and the parasympathetic. The sympathetic nervous system is your fight or flight nervous system. You may have heard that phrase before, fight, flight, or fright. The parasympathetic nervous system is your rest and digest nervous system. And we'll talk a little more about what that looks like. So if we were to start dividing out your nervous system, we'd start by making that distinction between your central nervous system and your peripheral nervous system. And then your peripheral nervous system can be divided up into somatic, which is all the muscles of your body, your skeletal muscles, and autonomic. Autonomic referring to all of that involuntary stuff, your smooth muscles in your organs, your glands, your heart, all the things that you don't control, you cannot control. Well, then we can divide the autonomic nervous system even further into our sympathetic, and our parasympathetic divisions. The sympathetic nervous system, like I said, this is fight or flight. You sometimes hear it called the fight, flight, or fright system. The sympathetic nervous system, generally speaking, serves to increase body function. So this will be things like increasing your heart rate, increasing your blood pressure, increasing your breathing. This is the division of the nervous system that you want functioning if you're trying to run away from a tiger. You're going to increase blood flow from your digestive system to your skeletal muscles. You're going to increase sweat. You're going to increase dilation of the pupils to get more light into your eyes. This is all what you need to do to get away from whatever is threatening you. Now, the parasympathetic nervous system, this is, you hear commonly called your rest and digest. This is not you running away from a tiger. This is you sitting on the couch on Saturday morning with a bowl of Lucky Charms watching Netflix. This is things that are going to overall decrease your body function. So this would be things like decreasing your heart rate, decreasing your blood pressure, decreasing your breathing rate. This system brings blood from your skeletal muscles to your digestion to increase digestion, constricts your pupils so you don't have as much light entering, decreases sweating. All of that is parasympathetic. And your body is constantly balancing back and forth between the two. You are rarely, if ever, completely sympathetic or completely parasympathetic. You're always finding a happy balance between them. Think of a dimmer for your light. You turn it a little bit and it gets a little brighter. You turn it the other way and it gets a little darker. That's how the balance between your sympathetic and parasympathetic nervous systems work in your body. So this is looking at the anatomic divisions of your nervous system. You can see the peripheral nervous system over here with your nerves, both cranial nerves that come off of the brain and spinal nerves that come off of your spinal cord. And then over on the right, we have the central nervous system that's made up of your brain and your spinal cord, everything that you find in your skull and in your spinal column. So the basic functional unit of the nervous system is the neuron. Usually when we talk about nerves and neurons and the nervous system, we talk about them all interchangeably. A nerve is a bunch of neurons. That are all bound together. But just one little cell is the neuron. There are two types of fibers in a neuron, axons and dendrites, that extend off of the cell body of a neuron. So if we have, here's our cell body for a little neuron, and you'll see extensions off of that neuron, or off of the cell body of that neuron in a couple of different ways. Usually when you see pictures of a neuron, they're going to look something like this. This is kind of our classic neuron. So here's the soma of the neuron, or the cell body. And then one of these projections is an axon, one of them is a dendrite. And which one is which is determined by how electricity flows through the cell. So if electricity is going this way through the cell, what we have at the top would be a dendrite. And what we have at the bottom would be an axon. Now, electricity only flows one way through a neuron. You cannot reverse the electrical signal going through it. So this part that takes electricity to the cell body, to the soma, is a dendrite. And then the extension down here that takes electricity away from the soma is the axon. Most axons are covered with myelin. It's a fatty sheath that wraps around the axon, protects the axon, insulates it, keeps it from getting electricity crossed with another axon, and significantly speeds up the electricity moving through the axon. You do see some axons that are not myelinated. They tend to be a lot slower than axons that actually do have myelin. In some of our chronic nervous system diseases, like multiple sclerosis, for example, what happens in multiple sclerosis is you see destruction of that myelin, and then electrical signals moving through the neuron start to slow down significantly. There are multiple types of neurons. A sensory neuron transmits impulses towards the CNS. This is an afferent neuron. Motor neurons transmit sensory impulses away from the central nervous system, and these guys are efferent neurons. Yes, I know these look the same. They will drive you crazy, but also I would know both of these for the quiz and the final, the difference between an afferent and an efferent neuron. Interneurons help to connect neurons within the central nervous system. You find a lot of them in the spinal cord and in the brain. A synapse is a point of contact between two neurons, where the axon of one neuron comes in contact with the dendrite of another neuron. And this is where electrical or neurotransmitters will flow from one neuron to the next to activate that neuron and cause an electrical signal. So here's our little motor neuron. You can see the dendrites out here bringing electricity to the cell body, and then the axon taking electricity away from the cell body. The synapse here is on a little muscle cell, so this is a motor neuron. So like I said, nerves are bundles of neurons, lots of tiny little cells all wrapped together in the peripheral nervous system. A ganglion is a bunch of cell bodies that you find along a nerve. So it will usually look like this big kind of lump along the nerve where all of the cell bodies of those neurons are. Most nerves are both sensory and motor, so they help you to feel things and they also help you to move. Some nerves are only sensory, some are only motor, but this is not quite as common. But if you do have a nerve that's only sensory or only motor, think about how that might affect what your patient feels or doesn't feel when that nerve is damaged. Maybe they lose feeling to their arm, but they can still move their arm. Or maybe the other way around. Maybe they cannot move their arm, but they can still feel their arm. These are some combining forms that refer to the nervous system. Obviously, neur or neuri refer to the nervous system, nervous tissue, or just nerves in general. Glia are neuroglia. These are the little helper cells of the nervous system that keep your nerves safe and protected and make sure that they have plenty of oxygen and nutrients. Your nerves are very needy. The glia are there to take care of them. And then anything with ganglia or ganglion refers obviously to a ganglion. Meningo or meninge refers to the meninges. Myelo, if you remember from the lecture on the musculoskeletal system, refers to both the spinal cord and bone marrow. Think practically when you're working through your homework about what you should put down for myelo when you see it in your homework. Right now, we're talking about the nervous system, so contextually, myelo should refer to the spinal cord. Anything with radiculo refers to a root. And then these are some suffixes that, again, I would know for the quiz. So phasia refers to speech, as does lalia. Lalia usually refers to like a babbling speech. Coprolalia is an example of that. Another one is echolalia. You see this sometimes in children who have autism, who can't speak very well. They'll usually just repeat back to you what you said. So you'll ask them, are you ready to go now? And they'll say, ready to go now. Or you'll say, please go get your shoes on. And they'll say, shoes on. That's an example of echolalia. Lexi, you've probably heard of dyslexia. Lexia is reading. If you have dyslexia, you have difficulty reading. If you have bradylexia, you have slowness in reading. And then plegia refers to paralysis. Paresis is partial paralysis, so not completely paralyzed, but partial loss. Epilepsy is a seizure. You've heard of narcolepsy. You've probably also heard of epilepsy. We'll talk about both of these in a little bit. And then you've probably heard the word phobia or mania. A phobia is a consistent, irrational fear. Mania refers to a very excited, very high energy state. So let's talk about the brain. The brain is found in your cranial cavity, hopefully, and is protected by a whole bunch of stuff to keep it safe up there. You have membranes that wrap around it called the meninges, cerebrospinal fluid that cushions the brain and protects it in the skull. And then, of course, the bones of the skull themselves are there to protect the brain and keep it safe. There are four main divisions of the brain that we're going to take a look at here. The biggest part of the brain is the cerebrum. This is made up of mostly white matter, so axons. The cortex, the very outer part of the cerebrum, is gray matter. This is cell bodies. This cerebral cortex is what makes you, you. This is where you get your consciousness, your awareness, your ability to talk and hear and see, your ability to think. All of that is this tiny, tiny, like 3 to 5 millimeter layer of cell bodies on the very outside of your brain. The brain is divided into two hemispheres. There's a big groove called the longitudinal fissure that divides those hemispheres together, or that divides those hemispheres. They're joined together by a little band of tissue called the corpus callosum, or large body. And this is the bridge between these two hemispheres in the brain. So here's our brain. This is the cerebrum, this big part, what you usually think of when you think of the brain. You can see it's divided into left and right, and then this is the corpus callosum that joins those two halves of the brain. The diencephalon sits underneath the cerebrum, and this contains something that we've seen before, the pituitary gland, when we talked about the endocrine system. So it contains a few things. The thalamus. The thalamus takes in sensory information. This is kind of the relay station of the brain. All of your sensory information goes to the thalamus first, and then the thalamus sorts that sensory information and sends it to the right part of the cortex where it needs to go. For those of you who have seen the movie Elf with Will Ferrell, classic Christmas movie, think about the scene in Elf when he is down in the mailroom helping to sort the mail. That's essentially your thalamus, but less creepy and less alcohol. Now, if the thalamus is the mailroom sorting the mail, the hypothalamus is sitting in the corner opening and reading everybody's mail. The hypothalamus is what controls the pituitary gland, if you remember that from the endocrine system lecture, and this is the link in between the endocrine system and the nervous system. So if you have information that comes into the thalamus, say that says, hey, we're really, really cold, the hypothalamus is going to see that and send that information to the pituitary gland. And then the pituitary gland will act accordingly to increase rates of thyroid hormone and then increase your body temperature. So here is your diencephalon, this little section of the brain right here, that incorporates the thalamus, which is right about here, the hypothalamus. What does hypo mean? This is the part below the thalamus, and then the pituitary gland, which we saw, like I said earlier, in the endocrine system lecture. Going down even further from the diencephalon, we see the brainstem, and the brainstem is made up of three parts: the midbrain, the pons, the medulla oblongata, which usually my students know from Waterboy. The midbrain has your reflex centers to make sure that what you're seeing and what you're hearing is very clear. It kind of clears up any blurriness that you might have in your sight, and it puts your pictures together properly so you see them properly in your brain. Your pons connects different regions of your brain, specifically your brain and your cerebellum, which is the little region behind your brain that controls your movements and muscle coordination, and we'll talk about that next. The medulla oblongata connects your brain and your spinal cord, and it controls a lot of your really basic functions: heart rate, blood pressure, breathing, all the stuff that you need to keep alive. This is one of the reasons why you can have significant damage to your brain. You can be brain dead, but still be breathing and your heart's still beating because the medulla is still working to keep all of that running. So down below the diencephalon here, we see the brainstem and the three branches to it: the midbrain up at top, the pons, which is this kind of bulging section of the brainstem right here. Pons actually is Latin. It means bridge. And the pons is a bridge between your cerebellum back here and the rest of your brain. You can see your cerebellum coming in at the back of the pons. And then the medulla oblongata, this pretty low section of the spinal cord that controls all of your basic stuff. It controls your breathing, your heart rate, it controls your diaphragm, your blood pressure, the things that you need to stay alive. So the last part of the brain then is the cerebellum. The suffix here, ellum, E-L-L-U-M, this is Latin. This just means something small. This is the diminutive form of a word. The equivalent to this would be ito or ita in Spanish, or et in French. This is just how you talk about something small. So cerebellum literally means little brain. So it kind of looks like a second tiny brain that someone stuffed back there behind the big one. It sits underneath the cerebrum, and it plays a huge role in coordinating your voluntary muscle movements. You can tell if a patient has had damage to the cerebellum because their movement will be very jerky and unsteady and unbalanced. The cerebellum also plays a little role in posture and in balance, but its main thing is coordinating those muscle movements. I will see if I can find a video of someone who's had cerebellar damage. You should be able to see very, very profound changes in how their muscles move. So here is the cerebellum, the little brain, sitting back here behind your cerebrum, underneath your cerebrum. And again, it does almost look like someone took a tiny little brain and stuck it back there at the back of your head. So to protect the brain, we have a whole bunch of stuff that's in the skull. Cerebrospinal fluid is produced in little ventricles in your brain. This stuff washes over your brain and also washes down your spinal column to support and protect your spine as well. This is the fluid that you remove from your spinal column if you do a lumbar puncture or a lumbar tap. You do that sometimes if you have a patient who maybe you suspect has meningitis or some other infection in the brain. You'll take that fluid out of the spinal column and test it and see what kind of pathogens, bacteria, or viruses you have. The meninges are 3 little membranes that wrap around the brain and the spinal cord and hold the brain and the spinal cord in place and protect them as well. The first one is called the dura mater. The dura means tough, mater means mother. So this is the tough mother. This is the outermost layer of the meninges. Very thick, very fibrous, really, really sturdy tissue. The second layer is the arachnoid. What does arachnoid mean? If you have arachnophobia, what is that? Arachnoid means spider. So this looks kind of like a spider's web. I'll show you in a little bit. And then the third layer is the pia mater. Pia means delicate. So this is the very delicate or soft or tender mother. And that's because this is a very, very thin, very easy to damage layer that's attached directly to the brain and the spinal cord. You cannot remove the pia without damaging the brain as well. The pia holds all of the blood vessels of the brain and the spinal cord onto the brain and the spinal cord. So you can see there's a bunch of pictures here. We'll look at this down at the bottom right corner first. This is just a little artist schematic of what the meninges should look like. You see the dura mater right underneath the skull, the arachnoid. Look at all the little kind of web-like projections holding the arachnoid to the pia, and then the pia that's directly attached to the brain. Now this is what happens in meninges, in meningitis when the meninges get inflamed. You can imagine there's not a lot of space in the brain for inflamed meninges, so those are going to compress and squeeze the brain and cause some pretty significant signs and maybe damage to the brain. The meninges also travel down the spinal column. This is looking at the spinal cord and the spinal column right here. Here is dorsal, your back up here, ventral, your front right here. And you can see there's this layer of epidural fat on top of the meninges, and then you see dura mater, pia mater, and arachnoid going in order down. This epidural space, if you have ever had an epidural, usually my students who have had babies know what an epidural is. This is where the needle goes when you get an epidural, into that little space that has fat there to protect and cushion the spinal column. And then that medication will diffuse from the epidural space into the spinal column and block the spinal column from there down. Looking over here on the left, this is an actual view of the meninges on the spinal cord. This big kind of sheet-like structure here that's been resected, this is the dura mater. And then you see these little denticulate ligaments right here that are attaching to the dura mater. That's the arachnoid. And then the pia mater, you can't see, it's this shiny layer that's holding these blood vessels onto the spinal column here. Remember I said you can't remove the pia from the brain or the spinal cord without damaging both the pia mater and the brain or the spinal cord. The external surface of the brain is divided into 4 lobes: the frontal lobe, the parietal lobe, temporal, and occipital. Frontal lobe is really big. It's found underneath your forehead, kind of the front of your brain. This is the part of your brain that does all of your planning and judgment and good decision making. This is the part of your brain that doesn't finish developing until you're like 25, 26. So this is why 14-year-olds make really dumb decisions. Back at the top and the back of your skull is your parietal lobe. The parietal lobe plays a role in language, in speech, and in hearing. The temporal lobe also does primarily hearing, a little bit of smell, a little bit of memory as well. And then in the very back is your occipital lobe. The occipital lobe is farthest from your eyes, so it controls your vision. I don't know whose plan that was. Some combining forms that you see for the brain, encephalo refers to the brain, if you've ever heard of encephalitis, inflammation of the brain, or anencephaly, absence of a brain. Cerebro and cortico both refer to the cerebrum, cortico specifically to the cerebral cortex, and then cerebello and thalamo obviously are cerebellum and thalamus, respectively. Ventriculo to a ventricle, medullo to a medulla. Psycho refers to mind. If you've heard the old Greek myth of Cupid and Psyche, that's where that comes from. If you're not familiar with Cupid and Psyche, I can find you something to read. Narco is any kind of stupor or unconsciousness. A narcotic is a drug that will make you unconscious or kind of put you into a stupor. If you have a patient who has narcolepsy, they get sudden attacks of unconsciousness. And then anything with somni or somno refers to sleep. So the spinal cord is your link between the brain and the peripheral nervous system. This is how we coordinate everything inside the central nervous system. It's wrapped up in your vertebrae, the little bones of your spinal column, and also protected not just by the vertebrae, but by your cerebrospinal fluid and also by the meninges. That should be an eye. The spinal cord extends from your medulla oblongata down to your lower back, between your first and second lumbar vertebrae. It stops there, and after that you have this big bundle of nerves that continues down your back called the cauda equina, or the horse's tail. There are a couple of terms that you should know for the quiz regarding the spinal cord: gray matter and white matter. Gray matter is cell bodies, ganglia. White matter are axons. They're white because they are covered over with myelin, and myelin is fat, and fat is white in color. Gray matter is the kind of central area of the spinal cord, and then the outer region of the spinal cord is white matter that has tracks that are going up to the brain or coming down from the brain. I'll show you in a little bit. Then there's a little central canal that runs through the spinal cord that carries cerebrospinal fluid that will wash over the spinal cord and keep it protected and safe. So here is our spinal cord going from the brain down to, like I said, about L1, L2 right here. And after that, we get this cauda equina. A big bundle of nerves that travel the rest of the back. So here are our divisions of the nervous system. You can see gray matter and white matter on this slide here. And yes, I know the gray matter looks white and the white matter looks gray. Interestingly, the spinal cord stains backwards when you stain it for a slide. Gray matter, remember, is cell bodies. White matter is axons. And different parts of the spinal column do different things. This little section, actually this little section down here is the DCML, the dorsal column medial lemniscus, that controls your proprioception. Down here you find branches of the spinal column that control movement. The different little tracks that we see here do different things and control different sensations, which can mean interesting things if you have a patient who only damaged part of their spinal cord. Maybe they lose their movement from that area of the spine down, but maybe they still have feeling, or maybe they lose their feeling, but they still have movement, or any number of strange things that can happen. There are 31 pairs of spinal nerves. This is also a number that I would know for the quiz. And you can group them in their segments based on which division of the spinal cord they come off of. So you have 8 cervical spinal nerves, 12 thoracic, 5 lumbar, 5 sacral, and 1 little coccygeal spinal nerve down there at your tailbone. Your nerves are attached to your spinal cord by 2 little roots, a posterior or dorsal root on your back that does all of your sensory stuff, an anterior root that does all of your motor stuff from your spinal cord to either a muscle or a gland. We talked a little bit already about your autonomic nervous system. Remember that the autonomic nervous system controls all the involuntary stuff that's going on in your body. And we break it into those 2 divisions, the sympathetic and the parasympathetic. Sympathetic is your fight or flight. Parasympathetic is your rest and digest nervous system. So sympathetic nervous system is going to do things like increase body functions, your heart rate, your respiratory rate. It activates your adrenal gland so you can make epinephrine. Remember, epinephrine's other name is adrenaline. And also delivers more blood to your skeletal muscles so you can run away from whatever's scaring you. Think back, if you remember that story from Fort Collins last year about the guy who strangled the mountain lion with his bare hands. He had a very active sympathetic nervous system. Parasympathetic nervous system is your rest and digest nervous system. You're decreasing all of those functions that the sympathetic nervous system increases. You're bringing your body back to a resting state. You're doing maintenance activities, digestion, repair of your cells, that sort of thing. Most of your organs have both a sympathetic and a parasympathetic function. And like I said, you're not always one or the other. You're not completely sympathetic or completely parasympathetic. You're usually kind of this happy balance in between the two. There are a bunch of key terms here that will be very useful for your homework and as you are studying for the quiz. I would go over these and make sure that you understand, make sure that you know which ones you understand and which ones you don't. So let's get into our pathology of the nervous system. We'll start with vascular stuff in the nervous system. A stroke is also called a CVA, or a cerebrovascular accident. In a stroke, you get low oxygen to the brain. This is the 4th leading cause of death in the US, the leading cause of paralysis and other issues with the nervous system. Lots of risk factors for a stroke. High blood pressure is one. Atherosclerosis, so buildup of fatty plaques on the inside of your arteries. If you've had heart disease, if you have diabetes, especially if it's not well controlled. Smoking is a huge one. And then unfortunately, strokes do tend to run in the family. So if you have, a family history of stroke, I would talk with your doctor about what you can do to decrease that risk. There are 2 types of strokes that you can have: ischemic and hemorrhagic. An ischemic stroke is caused by a block in a blood vessel, a blood clot or something like that that's blocking blood flow to the brain. A hemorrhagic stroke is just what the name indicates. This is a hemorrhage. A blood vessel in your brain ruptured and now you're bleeding out into your brain and your skull. Between the 2 of them, between the ischemic and the hemorrhagic stroke, which one do you think has better outcome? Your patient is more likely to live, less likely to have long-term complications, ischemic or hemorrhagic? Generally speaking, a patient with an ischemic stroke is going to do better for a couple of reasons. One, your patient with a hemorrhagic stroke, not only did they rupture a blood vessel, but now they're bleeding into the brain, and we don't have a whole lot of extra space in the skull for that blood to go. So it's going to cause a lot of pressure and compression on the brain. The other reason why your patient with a hemorrhagic stroke is not going to do as well as your patient with an ischemic stroke is because blood is actually toxic to the brain. The brain and your blood are separated via the blood-brain barrier that only allows very certain things to go from the blood into the brain to make sure that it's not exposed to the things in the blood that might damage tissue. So that's why your patient with an ischemic stroke is going to have a better long-term outcome, generally speaking. As you get older, the brain decreases in size, you lose brain cells. How much it decreases in size varies a lot depending on the person, but ultimately this means that your information is not processed as quickly, you have slower movement, your thought and memory process are slower, just everything slows down as you get older. Now, obviously, these changes that we see are very, very different among individuals. We probably all know at least like one 80-year-old who's still out there, I don't know, climbing 14ers on the weekend. If nothing else, think of Betty White. She's what, 95 and still going strong? So there's a lot that goes into how your brain is affected as you age that we don't understand very well. We're going to look at a bunch of common disorders and diseases of the nervous system, some infectious diseases of the nervous system, as well as cancers, and then we'll spend the last bit of the lecture talking about behavioral and psychiatric disorders. Usually my students are very interested in these. Thrombosis is formation of a blood clot. Remember that combining form thrombo. This means a blood clot. Usually when we're talking about thrombosis and the brain, we're talking about the carotid artery, the main artery in your neck that's running up to your skull. Take a minute, find your pulse in your neck. That's your carotid artery that you're feeling. If this thrombosis suddenly breaks off and starts to travel through the bloodstream, then we call that an embolism. So a blood clot, a stationary blood clot is a thrombosis. A traveling blood clot is an embolism. You diagnose this a couple of ways. A cerebral angiography is common. You inject dye into the carotid artery and then take a picture to see where that blockage is. You can do a CT scan as well. Depending on the severity of the thrombosis, treatment will vary. You can do an endarterectomy, which is going in and essentially scraping the inside of the carotid artery to remove that blockage. Or if it is a blood clot, you can do drugs that will help to break down that blood clot. We talked about aneurysms a little bit when we talked about the cardiovascular system. Remember, an aneurysm is dilation of a vessel, usually an artery. The concern with an aneurysm, especially when we're talking about the cardiovascular system, is that it can rupture and cause a hemorrhage and in turn a hemorrhagic stroke. There are lots of causes of aneurysm. Sometimes you can be born with them. You're just born with that weakness in the artery. It can be due to atherosclerosis. Hypertension is a huge one and often will cause rupture of an artery. Stroke from an aneurysm can lead to things like aphasia, which is lack of speech. Your patient can't talk anymore. Or hemiplegia, which is hemi is half, plegia is paralysis. So paralysis on one side of the body, usually the opposite side of the body from which the stroke occurred. So if you have a patient who has a stroke in their right half of their brain, the left half of the body will be affected. If the stroke was in the left half of the brain, the right half of the body will be affected. So here's an aneurysm right here. You can see the artery, and then look at this, the way that the wall of the artery has ballooned out, and look at how thin it is. You can imagine it would just take a little spike of really high blood pressure to suddenly cause that aneurysm to rupture. Trauma can look like a bunch of different things when we talk about the brain. A cerebral contusion is a bruise on the surface of the brain. You usually see these with a concussion. An epidural hematoma happens when you get bleeding in between the dura mater and the skull. Usually this is from a blow to the side of the head, really hard blow. Now, a subdural hematoma happens usually when you get a blow either to the front or the back of the head, and here you see bleeding beneath the dura, between the dura mater and the arachnoid. A concussion can happen, from any kind of hard blow or injury to the head. Usually with a concussion, you'll see the sudden loss of consciousness. When your patient comes to, they might have issues with amnesia, they might feel very dizzy, they might feel nauseous or throw up. And sometimes this can last for several days after the concussion. Your patient might feel kind of out of it. One of the issues with treating a concussion and making sure that your patient is safe again is that a concussion will often come with a contre-coup injury as well. And we'll look a little bit at what that means. So here are examples of different hematomas. An epidural hematoma you can see is on top of the dura. This is fairly easy to take care of. You just cut your patient's skull open and then allow that blood clot to fall out of the brain, basically. The subdural hematoma can be a little harder to take care of because it's beneath the dura, so you have to open up both the skull and the dura. And then the intracerebral hematoma, and that's actually inside the cerebrum of the brain. This is going to be even more difficult to deal with because you don't want to damage the brain, and also remember blood is toxic to the brain, so this may have more long-term lasting effects. So what is the idea of a coup injury or a contre-coup injury? So here's our patient right here. They got rear-ended in their car. And when they got rear-ended in their car, their brain slid backwards. They had whiplash really fast, and the back of their brain hit the back of their skull. This is the coup injury. Coup means touch. The contre-coup injury then, his head's not going to stay back like that. Now when he gets whiplash, his head's going to go forward, and the front of the brain is going to hit the front of the skull really hard. That's the contre-coup injury, the opposite of touch. Both of these need to be addressed as concussions, and both of these need to be watched to make sure that they heal properly so that your patient doesn't have, a repeat concussion in the same area. Confusion is any decreased comprehension or coherence or ability to reason. This is just a symptom that we see in a lot of different things. You could see it in a concussion. Things that you would see with confusion would be things like loss of memory. Either your patient can't remember things, could be short-term or long-term loss of language ability. Maybe they can't speak, or they can't read, or they can't understand what you are saying, reduced alertness, and then emotional changes that can look like anything. Very, very strong emotions of fear or anger in a patient that is not normally excessively fearful or angry. Now, a coma is unconsciousness from which your patient cannot be aroused. There are different types of coma. The one that we're talking about here is due to some kind of damage to the brain. Now, you can put a patient in an induced coma where you give them medications that put them into a coma, and then there are medications that will undo that induced coma and bring them back out. We're using that a lot right now to treat patients who have to be on ventilators for COVID-19. They're usually put into an induced coma, put on the ventilator, and then when they can breathe well on their own, taken out of the coma and revived. Now, a coma that your patient gets into because of damage to the brain is an entirely different matter. There are lots of things that can cause a coma. Injury to the brain is very common. Epilepsy can cause a coma for a couple of reasons. For one, epilepsy will significantly increase your body temperature if you have a patient who has really, really long, prolonged, ongoing full body seizures. All those muscle contractions will raise their body temperature and can raise it to the point where your brain starts to get damaged. It's about 106 degrees or so. At the same time that your patient's having the seizure, they're not breathing properly. Their diaphragm's not working properly, so they're not getting as much oxygen into their blood, and that will also, if this is a long seizure, like 5 or 6 or 7 minutes, can lead to a coma as well. There are certain toxins that will put you into a coma, metabolic imbalances, very high or low levels of certain electrolytes. And then when your patient goes into some kind of organ failure, they'll often go into a coma as well. This is the Glasgow Coma Scale. This is how we determine if a patient is actually in a coma. We look for 3 different behaviors. Do they open their eyes? Do they talk to you? Do they move? Your best response that you want from each one is that they do all these spontaneously. So you walk into the room and are their eyes just open? They're looking at you and looking around. That's good. That's hopefully all of you right now. If you walk into the room and they don't open their eyes until you start talking to them, then that would be this eye-opening response to speech. If they don't open their eyes when you start talking to them, so you get the needle and poke them with a needle or a pen, then that would be to pain. And then if you poke them with a pin and they still don't open their eyes, that would be no response. For verbal response, you want to see oriented to time, place, and person. So they're able to tell you, what is your name? Do you know where you are? Do you know what day this is or what year this is? If they're not entirely certain, that would be a score of a 4. If you get inappropriate words, you ask them, do you know where you are? And they say cucumber. That would be inappropriate words. If you ask them something and they don't say anything or they just make incomprehensible sounds, you ask them, do you know what day it is today? And all you get back is just kind of mumbling, maybe like you in the morning when you wake up. That would be a score of a 2. If you talk to them and they don't say anything, then that's just nothing, no response. Regarding motor response, what you want to see is they obey command. So you can say, raise your right arm, raise your left arm, and they can do that. Moving to localized pain, so if you poke them with a pin and then they'll move their arm. Flexion withdrawal to pain is less of a response to pain. So maybe you pinch your patient's fingernail bed and they try to move their hand away, but they don't raise their hand away from the pain. That would be this flexion withdrawal from pain. And then decorticate and decerebrate positioning. These are positions that the body goes into in very, very deep damage to the brain. These are bad signs. If your patient comes in decorticate or decerebrate position, they're probably not going to leave alive because they've had some pretty significant damage to the deep structures of the brain. So once you have scored your patient, you'll add up the score and see what you've got. If your patient has a score of 8 or less, then they are comatose. So let's say, for example, you have a patient who will open their eyes when you poke them with a needle. They make just kind of mumbly, incomprehensible sounds when you ask them their name, and they'll move a little bit when you squeeze on their thumbnail, but they won't raise their hand to try to get away from the pain. That would be a patient who technically qualifies as comatose. If your patient is completely unresponsive, they have a 3, they scored a 1 for everything, they may be completely brain dead, they may be actually dead. Let's look at some infections that we see in the nervous system. We'll talk a little bit about meningitis, which can be caused by bacteria or virus and causes inflammation of the meninges. Your common sign of meningitis is a stiff, painful neck. This you'll usually diagnose with a lumbar puncture, though there are other ways you can diagnose meningitis. Viral meningitis will often cause encephalitis, inflammation of the brain. There are other viruses that can contribute to encephalitis as well. So meningitis is acute inflammation of the meninges, usually viral, can be bacterial, sometimes caused by amoebas even. Your classic signs of meningitis are a stiff neck, and that's what we see in this picture up here in the top right. This was a picture taken in Texas back in the early 1900s. There was a bad meningitis outbreak there, and you see in this patient in the picture, his neck's pulled far back, his head is pulled back as far as it can go. That's what they mean by stiff neck. A high fever, and then some kind of altered mental status, confusion, not responding to speech, that sort of thing. Now the issue is you only see these symptoms in about 45% of all of your bacterial meningitis cases. So there are other things that you'll look for. Photophobia, intolerance to bright light. You pry their eyelid open and shine a bright light in there, they probably will not respond well. You'll also see intolerance to loud noises as well. And then often this spreading rash, and that's what we see in our baby right here. This spreading rash, this is not actually a rash like you would think of a rash with measles or with smallpox or chickenpox. In reality, this spreading rash that we see is DIC. Meningitis gets into the blood very easily, and when it gets into the blood, it causes the blood to start to form little clots, and those clots result in DIC, disseminating intravascular coagulation, or little blood clots all throughout the blood vessels. Well, this is bad because if those clots get together, they can block blood vessels, and then you're not getting blood to tissue, and if tissue doesn't get blood, it dies. And that's actually what we're seeing in this baby right here. So you see how her fingers have all turned black right here, these black patches of skin on the back of the arm. That is skin that's been blocked off by blood vessels, blood's not getting to it anymore, and it's dying off. Believe it or not, this baby actually lived through this bout of meningitis. She's in either Australia or New Zealand, I don't remember. She lost, I believe, all 4 limbs, both arms and both legs, because of the DIC, and has since then kind of become the poster child for getting your kid vaccinated against diseases that cause meningitis. So there are a lot of vaccines that will protect against diseases that could cause meningitis. Mumps causes meningitis. There's the meningococcus vaccine, the HIV vaccine, Hib, that is usually given to very young children. I think that's what that baby had. All of these reduce your risk of meningitis significantly. Infections, more infections that we see of the nervous system. Shingles is a nerve infection that you get if you have had chickenpox in your body, that herpes zoster virus. If you had chickenpox as a child, that virus never leaves your system. Your body never kills it off. It just goes and hides in your nerve root up by your spinal cord and hangs out there and waits and waits and waits, and then later in life gets activated. Maybe you have an infection or you have a time of very high stress, something like that. That will activate that nerve or that virus hiding in your nerve, and then it will travel down your nerve and erupt on the patch of skin that that nerve innervates. And that's what we see in our patient here with this strip of rash. This is very, very painful, can take a long time, months, for a shingles infection to go away. And if you get it close to your eyes, it will make your doctor very nervous because you might have issues with your eyes or even blindness. Now, there is a shingles vaccine that you can give. Usually you give it to older patients. That will decrease their risk of this herpes zoster virus reactivating and keep them from getting shingles. Oh, look how cute. They're all fuzzy and fluffy. He's smiling at you. What do all these guys have in common? We've got skunks and bats and raccoons and foxes. What do they all have in common besides being cute and cuddly? These are all our host species for rabies. The rabies is a virus. It's transmitted through the saliva of an infected mammal. You can only get rabies from a mammal. What is a mammal? A mammal is anything that makes milk to feed its young. So are birds mammals? My students usually get into a fight about this. Birds are not mammals. Birds cannot transmit rabies. Reptiles cannot transmit rabies because they are not mammals. Rabies causes inflammation of the brain. The virus for rabies actually grows and replicates in the salivary glands in the head, and that's why rabies is transmitted through saliva. Your initial symptoms of rabies are, generally speaking, mild flu-like stuff. Fever, weakness, muscle ache, headache, and that sounds like the flu, right? Sometimes you'll see at the bite area this kind of prickling or itching, and that's a sign that the virus is starting to replicate in the body. And then it can take a pretty short amount of time to go from those initial symptoms to some really scary stuff. Between 2 to 10 days, you'll get hallucinations, delirium, confusion, insomnia, agitation. One of the classic signs of rabies used to be called hydrophobia. What does that mean? Hydro is water. And then phobia is a fear of something, literally fear of water. And the reason for that is because the muscles of the throat become paralyzed. It's very hard for your patient to swallow, so they don't want to drink because they're scared they'll choke. Once these symptoms have manifested, these really scary nervous system symptoms, the disease is almost always fatal. The best we can do is put you in an induced coma and give you last rites, keep you comfortable until you die. So let's say you get bit by something. You're out on a walk and you are playing with the wildlife and you get bit by a raccoon. What should you do? Well, as soon as you've been exposed, obviously wash the wound and then go to the ER. And when you get to the ER, they'll ask you, have you had your rabies shot? And probably most of you who are listening to this will say, no, I haven't, because the rabies vaccine is not just handed out. This is not one of our standard childhood or young adult vaccines. You usually only get this if you request it because you're being exposed to certain populations or areas where there's a lot of rabies. So since you haven't had your rabies vaccine, the ER is going to give you your first rabies vaccine. It's a series of 3 that you get over 6 months. And because they don't want to wait 2 weeks for you to start making antibodies, they're also going to give you an infusion of anti-rabies antibodies that will help your body start to fight off the rabies if there's any in there. This treatment, if you go in and get everything taken care of right here, this treatment is 100% you will not get rabies. Now, if you wait, right, I got bit by my raccoon, I'm just going to wait and see if I get any symptoms. You know, I feel fine now. If I feel bad, I'll go to the ER. If you wait till the time that symptoms appear, the best we can do for you is, like I said, stick you in an induced coma and keep you comfortable until you die. There is no treatment for rabies after you start to show those symptoms. Now, that said, there has been one person who has actually survived rabies after she started showing the neurological symptoms, the hallucinations and the delirium. And the doctors who were treating her put her in an induced coma, significantly lowered her body temperature, and then pumped her full of antiviral drugs. And she actually survived with no long-term effects, no long-term brain damage. They call it the Milwaukee Protocol because this was done in a hospital in Milwaukee. Now, since then, this same protocol has been tried on several dozen people who have been exposed to rabies and have showed symptoms, and it has not worked. So there's a lot of debate now about whether or not this really is a protocol that you can use to treat rabies, or whether that first patient got really lucky. I think probably, truth be told, she got very lucky. Now, Colorado has had some issues actually with rabies in the past few years. You can see here, this is data from the CDPHE, the Department of Public Health and Environment. You can see from 2016 to 2018, we had some pretty significant spikes in rabies. Back in 2018, we had 312 cases of rabies. This is rabies in animals. Confirmed cases of rabies in animals, not in humans. 312 cases of confirmed rabies in 2018. That's a lot. Now, fortunately, we dropped back down to 163 in 2019, but that's still a lot of cases of confirmed rabies, and obviously doesn't count the ones that we don't find. As of today, May 30th, we've had so far 26 cases of confirmed rabies in animals across the Front Range. And this spike in rabies has caused a lot of concern, and there's been a lot of newspaper inches written about it. Northern Colorado is crawling with rabid animals this summer. What's going on? I like that image of crawling with rabid animals. Or we have 27 animals test positive for rabies back in March of 2018. This is my favorite right here. 21 people treated for rabies after Weld County woman brings baby raccoon into home. Don't play with the wildlife, guys. Rabies treatment is expensive. Rabies in Colorado, a special report. This is from the public health veterinarian for the state of Colorado. So she talks about the presence of rabid animals in densely populated areas is troubling. Last year, 2 dogs in Colorado got rabies. So make sure that all of your pets have their shots, both dogs and cats, no matter how much they stay inside or outside. Let's look at another infectious disease of the nervous system. What on earth is going on here? A lot of the time my students look at this picture down here on the bottom and they say, wait, isn't that rickets? It's not rickets. It looks kind of similar to it. Polio is a viral infection. This infects the brain and the spinal cord. This is spread from person to person. We don't find this in any populations outside of humans. This is not like rabies that hangs out in other animals. Polio is spread, much like many of our diseases, fecal-oral. What does that mean? That means that you're getting some kind of contaminated food or water, contaminated with feces, that's getting into your mouth and you're consuming it. Most people who develop polio will be asymptomatic. A very small percent, about a quarter of them, will develop flu-like symptoms, and of those, a small percent will develop some really concerning neurological symptoms. They can get meningitis, paralysis, paresthesia, which is this kind of feeling of prickly pins and needles in your fingers and your toes and your hands and your feet. In patients who do develop paralysis, there's a 2 to 10% fatality rate. 10% is pretty high. The big concern with polio is this post-polio syndrome. So in patients who have had polio, you'll see this weakness and atrophy of the muscles that can sometimes take years to show up. So think about what this means for that 75% of people who are asymptomatic. You have the kid who maybe had polio and didn't show any symptoms when he was 5, and now he's 35 and suddenly developing this really profound muscle weakness and wasting and breakdown. This affects a pretty big percentage of survivors. 25 to 40% of people who have polio will develop post-polio syndrome, and that's one of the big concerns about polio. There is no cure for polio. We do, however, have a vaccine. We have 2 vaccines. One is oral, one is injected, and these vaccines are wildly effective against polio. If you remember the smallpox lecture from the integumentary system weeks and weeks ago, polio is kind of the smallpox of your generation. We are very, very close to eliminating polio. In 2018, there were 33 cases. In 2019, I don't know what happened. We had about 5 times that much. As of today, May 30th of 2020, there are 12 cases in Afghanistan and 28 in Pakistan. These are the last 2 places where we see wild-type polio circulating through the world. So this is showing that steady decrease in polio. The World Health Organization decided back in 1989, 1988 to eradicate polio. Remember, we did it with smallpox. Let's try it again. The Americas and China were certified polio-free in '94. Last case of polio in Europe was in 1998. And then since then, it's just been this long, slow trek across the developing world to try and wipe out polio there. India got their polio-free certification in 2014. That's a really big deal. Nigeria was recently declared polio-free. In 2016, we had 37 cases globally. So we're very, very close. Hopefully soon. Who knows, maybe within the next 10 years. You guys will hopefully live to see polio eradicated in your lifetime. So the places where we still see polio, Pakistan, Afghanistan, are these like nice cushy places where you want to go work? Are they very peaceful? Are they very stable? You see a lot of issues with vaccine workers actually being kidnapped and killed in Afghanistan and Pakistan. This is one of the reasons why these countries are our last stronghold against polio. It's going to be very difficult to eliminate. Difficult, but not impossible. This is just showing polio cases by year for those two countries, Pakistan in green, Afghanistan in red. You can see Pakistan's kind of our key player here. This is the one that has the majority of our polio cases. Another infectious disease, this one's been in the news a great deal recently. What is going on here? All these babies with these little tiny heads. So Zika is another virus. This is a vector-borne virus. This is transmitted by Aedes. It originally was found in Uganda, near, I believe, the Zika River, which is where it got its name, and since then has spread across the world. Symptoms of Zika virus, much like most of our viruses, usually your patient will be asymptomatic. If they do have symptoms, they're usually flu-like. The concerns about Zika virus are some of the long-term effects. Zika virus can cause Guillain-Barré syndrome, which is a paralysis of the limbs. And then the big thing that we kind of weren't quite aware of until Zika hit Brazil and we suddenly had this huge population with Zika virus is that it can cause some pretty nasty pregnancy complications. It increases the risk of miscarriage, of stillbirth, preterm birth, also of microcephaly, which is what we saw in those previous pictures of those babies. Between 5 to 15% of babies who are born to women who are infected with Zika while they were pregnant will have some kind of complication, and the risk of complication increases if that infection happened during the first trimester. So we know that Zika can be transmitted across the placenta. This one is also new that we discovered from Brazil. Zika can also be transmitted sexually. We found that out when a researcher who had been down in Brazil working on Zika came back home to Denver and gave his wife Zika. So that's new. There is currently no treatment for Zika. There are a bunch of vaccines in research. The type of virus that Zika is by nature kind of difficult to make a vaccine for. This is just showing how Zika spread from Uganda over to Nigeria and then east across the Pacific until it hit Brazil back in 2014, 2016. Now, there was a little Zika in Florida and Texas in 2016 and 2017 when that first outbreak occurred. Currently, there is no endemic Zika. Endemic just means that the virus is here and living here. The Zika that we saw in Florida and Texas was brought back from people who were traveling outside of the country. But you can see in this picture here, Aedes mosquitoes, Aedes aegypti and Aedes albopictus, have a pretty big range in the U.S., even a little bit of Aedes albopictus in northeastern Colorado. So could we expect to see endemic Zika in the U.S.? Yeah, we could in theory see all of these Aedes mosquitoes spreading Zika throughout the country. That would be very interesting and also terrifying if that happened. Last of our vector-borne infectious diseases is West Nile virus. This is one that we hear about all the time in the summer here in Colorado because this is endemic. This is viral. This is also transmitted by a mosquito. It's transmitted by the Culex mosquito, not the same as the Aedes. Also discovered in Uganda, came to the U.S., made it to New York City in 1999. West Nile infects humans, and then birds and horses tend to be hosts for West Nile. This is a leading cause of mosquito-borne disease in the U.S., just because we don't really have any other mosquito-borne diseases. Like our other stuff, West Nile is usually asymptomatic. About 20% will develop some kind of fever, kind of flu-like symptoms, and then this fatigue that can wipe you out for a really, really long time. A very small percentage, 1 in 150, will get really severe neurological symptoms, meningitis, encephalitis, with long-term effects. It can take months and months to recover from this. And then if you do get these really scary nervous system symptoms, there's a 10% chance that you'll die. There is no treatment, no vaccine right now for West Nile. So the best treatment is prevention. The majority of West Nile infections happen in August and September. It's warm out, everybody's outside getting exposed to mosquitoes. So, good ways of keeping from getting bit by mosquitoes, make sure you have long sleeves and long pants at dawn and dusk because that's when Culex mosquitoes are most active. Use good mosquito repellent, something like DEET. Make sure that you empty any standing water. Make sure you have window screens. And then if you see lots of sick or dead birds in your neighborhood, call the local public health department because they're probably going to want to take those birds and test them for Zika and see if maybe you have an outbreak in your neighborhood. Okay, moving on from infectious diseases. A neoplasm is a growth, a tumor. Most of the tumors that you see in the nervous system involve the glia, and we call these gliomas. Gliomas will come sometimes with odd symptoms depending on where in the brain they are. You might see seizures, you might see very severe headaches, sudden vomiting without any cause, sometimes muscle weakness, sometimes issues with one of your senses, your patient's hearing or vision or taste or smell are starting to go. Gliomas are difficult to remove. They tend to have lots of little projections. They weave their way through the brain, so it's hard to surgically remove an entire glioma. And because of that, because it's hard to get drugs that pass into the blood-brain barrier, usually your patient with a glioma has a very short lifespan after diagnosis. On average, after diagnosis is about 18 months, about a year and a half that your patient will still be alive after they've been diagnosed with a glioma. Meningioma is a tumor of the meninges. This can usually be removed surgically, usually has much better outcomes than a glioma. Multiple sclerosis is a degenerative disease. You see breakdown of the myelin that covers the neuron. And remember, our suffix sclerosis means harden. So you see hardening of the nerves as well. Initial symptoms are usually issues with balance and sometimes a tremor in the hands. That's often what will bring your patient in. You'll see problems with vision as well, sometimes tingling and numbness in the arms and the legs, urinary incontinence, stiff gait, difficulty walking. Your patient may eventually need to be in a wheelchair. The cause of multiple sclerosis is not well understood. You tend to see multiple sclerosis almost exclusively in the northern hemisphere. So there are a lot of hypotheses about, well, maybe it's a chronic lack of vitamin D. But right now I don't think there's anything solid that is being put forth as a hypothesis behind what causes MS. MS symptoms tend to go in waves. Your patient will have really, really profound, really severe symptoms of multiple sclerosis, and then those symptoms will go away for a little while, and then they'll come back even worse. Parkinson's disease is another degenerative disease of the brain. This we do know what happens. The midbrain neurons stop making dopamine. Dopamine is a neurotransmitter. It's responsible for initiating movement. And that's why you see in patients who have Parkinson's disease, they don't move very quickly, and it takes them a very long time to get started moving. It's also responsible for feelings of reward, pleasure seeking. So you'll see emotional issues, changes in emotions in your patient who has Parkinson's disease. Usually you see a lot of tremors, especially of the hands and the arms, muscle rigidity, flexion at joints, slowness initiating movement, akinesia, lack of movement. Treatment for Parkinson's disease is often this medicine L-Dopa. You're just giving your patient dopamine. The only issue with treating your patient with L-Dopa is if you give too much dopamine, then you cause these uncontrollable movements of the muscles called tardive dyskinesia. Which is another very unpleasant condition. There is new research going into implanting electrodes into the brain of a patient who has Parkinson's disease to stimulate the parts of the brain that are not working properly. And this tends to have very, very good effects for your patient with Parkinson's disease. Now, generally speaking, people are very nervous about having electrodes stuck in their brain, but You usually only have to, you only do the surgery once, and after that, you usually don't have to have any kind of other treatment for Parkinson's disease. Alzheimer's disease is degeneration of the neurons, generally that make up the cerebral cortex. What causes it is not well understood. We know that your patient will start to see loss of memory, usually very recent memory. You have to repeat yourself a lot to them, sometimes confusion, mood swings. We've thrown so much money at Alzheimer's research, billions of dollars that have gone into Alzheimer's research, and are nowhere nearer to finding a cure than we were when we started, or even the cause of Alzheimer's disease. And there are a few hypotheses about that. Right now, the big one is when you start testing experimental medications for Alzheimer's disease on a patient who has Alzheimer's and is showing symptoms of Alzheimer's, maybe it's too late. Just like how if your patient comes in showing signs of rabies, it's too late to treat them. So new research is starting to look at how do we find the patient, not the patient who has Alzheimer's, but the patient who's going to get Alzheimer's in 10 years, and use them to start testing our medications for Alzheimer's disease. And that is hard. How do you find that patient? We haven't figured that out yet. Multi-infarct dementia looks like Alzheimer's disease, but this is lots of tiny strokes in the brain that cause very similar symptoms to Alzheimer's disease. Usually if you put your patient in a CT or an MRI, you'll be able to see those little strokes and the damage to the brain, and then you'll be able to make that diagnosis. Is it Alzheimer's? Is it multi-infarct dementia? Epilepsy is abnormal electrical activity in the brain. There are different types of epilepsy. Usually when we talk about seizures, my students are thinking about like the person who's lying on the floor having a seizure, twitching and convulsing. That's a grand mal seizure, and that is definitely a form of epilepsy. But you can also have patients who have seizures that are very, very small. I had a friend once who had epilepsy. She had very petit mal seizures. You would be talking to her, and then all of a sudden she'd just stop and stare off into space for, 30 seconds, 45 seconds. And then suddenly she'd come back and start talking to you again, and usually wasn't even aware of what had just happened. So that's an example of a petit mal seizure. Really serious seizures, big grand mal seizures, you'll see loss of consciousness, convulsions. Like I said earlier, if these seizures last for a very long time, that can be incredibly damaging to the brain. You diagnose epilepsy with an EEG, an electroencephalogram, that measures brain or electrical activity in the brain. That's what we see in this picture right here. He's hooked up to an EEG that's going to look at the way electricity is moving through the brain. And then medications that you'll use to treat epilepsy, anti-epileptic, anti-convulsive medications that generally speaking are pretty good. Of course, there are plenty of people who are here in Colorado trying out different strains of CBD for epilepsy for themselves or their children. Some of it seems to be promising, but that research is sometimes hard to nail down. Dysomnia is any term for abnormal sleep. Remember, our prefix dys means abnormal or difficult. So insomnia is insufficient sleep or non-restorative sleep. Either you're not sleeping, it's taking a very long time to fall asleep, you wake up very early and can't get back to sleep. Narcolepsy is a sudden attack of sleep. Treatment for this is usually some pretty heavy-duty stimulants. I had a classmate in grad school who actually had narcolepsy. After we finished in our neuro class talking about narcolepsy, she showed us her medications that she had in her backpack. She was basically carrying around a bottle of methamphetamine on campus with a doctor's note about why she had meth in her backpack. But those are the kinds of stimulants that you treat narcolepsy with. Sleep apnea is cessation of breathing for a short period during sleep. Usually you see blockage of the upper airway. As your patient relaxes into deep sleep, the muscles and the tissues surrounding the throat start to collapse and block the airway, and your patient starts to choke. And then they'll wake up, but not all the way. and that waking back up will lift the tissues of the throat back off of the airway, and they'll be able to breathe again. So what this results in is a patient who snores really badly, is thrashing around all night long, and usually doesn't know that they have sleep apnea. Usually, the way that this is diagnosed is the person in the bed next to them says, "You snore terribly and you thrash around all night long," and eventually they go into the doctor. You'll diagnose this with a physical examination and usually do sleep history, sleep habit, maybe a sleep study even, which is what's going on in this picture right here. You'll get hooked up to machines that will measure your oxygen and will measure your brain activity as you sleep, as well as the way that your eyes are moving, what stages of sleep you're in. You'll do this sometimes in a sleep lab, sometimes they can send you home with the devices that will do that. And then by looking at the changes in your body, the changes in your blood oxygen as you sleep, you can make that diagnosis of, yes, this patient does have sleep apnea. Treatment will be a CPAP machine that forces pressurized air into the respiratory system, and that will keep the trachea and the pharynx open while your patient's sleeping so that they don't choke as they're sleeping. Okay, now we're going to take a look at some behavioral disorders, psychiatric disorders, again, with the full disclaimer that I'm not a trained psychiatrist or psychologist. So if you have questions about any of these topics, email me and I will do my best to answer them. So there are a few different things that fall under an anxiety disorder. Now, one is just generalized anxiety disorder. This is chronic, excessive, uncontrollable worry, usually not about one particular thing, just this always simmering stress and worry. Usually you'll see, along with the mental signs, lots of physical stuff as well. Tense muscles, restlessness, difficulty breathing, heart palpitations, insomnia. Think about when you feel very anxious or very nervous, and then kind of crank that up to 11. A panic disorder is something akin to generalized anxiety disorder, but with episodes of sudden, very intense fear. Quite often your patient will be very afraid that they're dying or feel like they're dying. In a phobia, you see anxiety and fear, but geared towards a certain object or situation, usually irrational fear towards that object or situation. Treatment for a phobia generally involves exposing your patient to what they're afraid of slowly over a long period of time. So say you had a patient who had a phobia of snakes. You might start by talking about snakes, and then maybe you would look at pictures of a toy snake, and then you would handle a toy snake, and then you would look at pictures of real snakes and maybe watch videos of someone handling a real snake, and then you would watch someone handle a real snake, and then eventually you would handle the snake, but over a very long, controlled time frame. Obsessive compulsive disorder, or OCD, you see these repetitive behaviors that arise to relieve whatever the anxiety is that your patient has. An example might be, maybe I'm afraid that someone is going to break into my house while I'm sleeping. That's my anxiety. So the repetitive behavior that I do to relieve that anxiety is going around and checking all the doorknobs before I go to bed to make sure that all the doorknobs are locked. Okay, but then when I go back to bed, I still have that anxiety of, well, what if someone does break in? What if I missed a doorknob? So I go back and check all the locks on the doors again. And that's where this repetitive building of the behavior comes from. And the behavior becomes very soothing. This is how you relieve the anxiety. Post-traumatic stress disorder, or PTSD, is anxiety, among other things, usually caused by some very stressful or very catastrophic event, something traumatic. Usually with PTSD, you'll see all sorts of emotional issues: fear, anger, guilt, grief, depression, depending on what caused the PTSD. Treatment for this is generally talking about whatever has caused the PTSD, but that can be hard because talking about that will put your patient's mind and even their body back into the situation that they were in when the traumatic event happened. So there are a number of different therapies that are used to help relax the body so that the mind can then process what happened during the traumatic stress event. Eye movement desensitization therapy is very helpful for that. Interestingly, there have been some studies done on ecstasy, the street drug ecstasy, giving that to the patient and then having them talk about whatever the stressful event was. And the ecstasy relaxes the body and the patient is able to talk about what happened without their body being tense, being in the same situation that they were in with the PTSD. Now, on the other side of the spectrum, we have depression, which, just like anxiety, you usually see emotional and physical conditions intertwined. We characterize or diagnose depression by these three here. If your doctor has ever screened you for depression, they'll ask you, have you had feelings of sadness? Have you had feelings of hopelessness? Have you had lack of interest in activities that you like to do for the past 2 weeks? And if you say yes to that, then you'll usually be referred to a specialist to then kind of figure out what is going on and start with some kind of plan for treatment and therapy. There are different types of depression. Dysthymia is depression that you usually see after a very serious event. Bipolar disorder, you see depression with episodes of mania, these very strong mood swings from high to low. Your patient will be very depressed, and then they'll go into this manic episode of just uncontrollable energy, uncontrollable activity. Usually they'll do a lot of things in a manic episode that they wouldn't normally do. They'll go spend all their money at Blackhawk at a casino, or they'll buy a bunch of stuff they don't need, or maybe jump in an airplane and go on a trip, or do drugs or alcohol or sleep with people they wouldn't normally sleep with. Usually it's crazy, unpredictable behavior. And then quite often that behavior will send them back down into a depression once they see, how much money I spent or what I did or how my manic episode played out. Treatment for bipolar disorder is usually lithium that will balance both of those mood swings, the depression and the mania. Psychosis is a mental state where your ideas of reality have become skewed. You'll see with psychosis delusions, paranoia, hallucinations. The hallucinations can take any form. Usually when you think of hallucinations, you think of hearing something, seeing something. You can have a patient who has psychosis who is smelling something or feeling something that's not actually there. Doesn't necessarily have to be auditory or visual hallucinations. Now, chronic psychosis, when you constantly have this misconception of reality, this is schizophrenia. A lot of the time when we start talking about schizophrenia in class and I ask my students what's schizophrenia, they'll say something to the term of, well, it's when you have multiple personalities. That is not schizophrenia. That's dissociative identity disorder. Those are two different things. A patient with schizophrenia has chronic psychosis. So they're constantly having hallucinations, quite often hearing things that aren't there, having issues with paranoia, sometimes delusions, feeling like the people around them who love them are actually out to get them. Schizophrenia usually crops up in young adulthood. Usually late teens to like mid-20s is when you tend to see schizophrenia first show up. And it usually comes after a period of mania. You see this a lot with, say, the college student who is in the middle of finals and is studying really, really hard and doesn't need to sleep and doesn't need to eat. And I have so much energy and focus all of a sudden. You see this ramp up of a mania, and then quite often after that, you see this schizophrenic break. All of a sudden they're hearing things, they're seeing things. Schizophrenia is hard to treat. We have medication that's pretty good for schizophrenia, but it also has some pretty strong side effects. A lot of the times a patient who's on medication for schizophrenia will say that while they don't have hallucinations anymore, they also don't really feel anything. They feel very blank or numb. The medications are rough. So it's not uncommon to see a patient with schizophrenia go off of their meds once the hallucinations have stopped because they feel a lot better and they don't like the side effects. And then unfortunately, they'll go back into another psychotic break. So treating schizophrenia, keeping a patient with schizophrenia on their medication can be very, very challenging. ADD, ADHD, attention deficit hyperactivity disorder, also another one that can be kind of difficult to diagnose. Usually the diagnosis comes in childhood, elementary school age. And one of the reasons that it's difficult to diagnose is because signs and symptoms of ADHD or ADD look very different in boys versus girls. If I say you have a patient who's coming in and this patient is coming in with his kid who has ADHD. Like, what does the kid look like? What pops up in your mind? When I ask my students this, they usually say it's a boy, little boy, and he's just off the walls. He's getting into things, he's causing trouble, maybe throwing tantrums, won't stop talking, just go all the time. Can't sit down, can't focus on anything. And that is true for boys with schizophrenia, with ADHD. They tend to have very high outward focused energy. Girls who have ADHD usually don't have the high outward focused energy. Instead, they tend to be very internal. This is the girl in class who's just daydreaming and constantly off into space, always forgetting her homework, always forgetting to do her assignments. This is what you commonly see in girls with ADHD. And there's some speculation that girls are underdiagnosed for ADHD because you're looking for the signs and symptoms you would see in a boy. Now, if you catch the diagnosis of ADHD early, there's a lot that you can do in the way of psychotherapy and behavior therapy, helping the child control that energy, teaching them techniques and tools that they can use to focus. Also, of course, medication, things like Ritalin, which will help the imbalance of stimulus in the brain. Autism is a disease that shows up on a spectrum. You can have patients who are very severely affected by it, patients who have kind of lighter or more minimal autism. It affects the way that your patient will interact with other people and the way that they'll communicate with other people. It can make that very difficult. Sometimes with autism, you'll see individuals who are very, very bright, but the autistic savant that you often hear about is fairly rare, a very small percentage of the population, and quite often you see issues with intelligence or intelligence impairedness. So autism is very, very complex. Right? Despite whatever the person selling you essential oils might say on the internet, we do not know for sure what causes autism. Right now, the hypothesis is just a combination of the right kind of genes and the right kind of environment. There's a saying that genetics loads the gun and environment pulls the trigger. And this is true about autism. It's true about a lot of other things as well, that you have to have that kind of perfect balance of genes and environmental influences to trigger autism. Usually signs of autism will show up pretty early in childhood, between about 2 to 6 years of age. And you'll see things like self-absorption. This does not necessarily mean that the child is all about themselves, but that they have a very hard time coming out of themselves, out of their own life, and interacting with the stuff around them. They tend to be very interior. Lack of response to social contact, to affection, not understanding social cues, reading facial expressions can be very difficult for children with autism. Picking up on sarcasm is very, very hard for children with autism. Like I said, sometimes you'll see issues with low intelligence, but sometimes this can be because of poor language skills. It's common for children with autism to start talking later in life than a child who doesn't have autism. So sometimes that the issues with low intelligence, maybe it's that, maybe it's just that the child doesn't speak, doesn't know how to communicate themselves. They tend to be very easily kind of overwhelmed by loud noises, bright music, or loud noises and loud music, bright lights, big crowds, lots of people can be very overwhelming. And sometimes that'll lead to self-destructive behavior, hitting themselves, for example. Now, you often hear this contrasted with Asperger's, which is very high-functioning autism. Often, people with Asperger's tend to be very smart and very verbal, and usually are very, very good at memorizing stuff. They tend to be good at memorizing facts. Now, a lot of this highly intelligence tends to be kind of rote intelligence. They're very good at memorizing things, not always good at then taking the facts that they've memorized and turning that into something they can do with it, or making changes based on those facts. Again, trouble with social interactions, with understanding the motivation behind what others do and what they say, trouble reading facial expressions, usually fairly isolated as children, and usually will develop repetitive behaviors, rocking back and forth, flapping their hands as a means of self-soothing. And usually someone with autism or Asperger's has a very, very deep interest in a very few things. They're very, very interested in trains, or in dinosaurs, or in genetics, or in the solar system. It tends to be a complex topic, and they dive very deeply into that. So different medications that you'll see used in treatment for neurological or behavioral disorders. Any drug that acts on your mental state is called a psychotropic drug. Psycho here, this is our word psyche in Greek, that means mind, or literally spirit. And then tropic means something that will create activity in it. Different types of drugs that you see in behavioral conditions, anti-anxiety medications, mood stabilizers. This would be something like lithium for bipolar disorder, antidepressants, antipsychotics for something like schizophrenia. And that is that for the nervous system. Thank you for hanging in there. I know this is a very long lecture. Hopefully you took a break once or twice. As always, if you have any questions or would like further information on a topic, shoot me an email, shoot me a text, drop by office hours. I would love to see you there.